For everybody with an interest in MASH or more broadly steatotic liver disease, Surf's Up. Season 4, episode 48 of Surfing the MASH Tsunami, our individual interview portion of our liver meeting in meeting coverage, starts now.
Today, on Surfing the MASH Tsunami.
There are a number of diseases where looking at past blood tests, you can make a diagnosis really rapidly. So that's kind of the easy bit, that's the low-hanging fruit. Mm-hmm. Going on from there, we think the power of this is in sort of population-level risk stratification. So huge numbers of people have had blood tests, nobody's taken a look at that and said, what's the pattern? Are these people at risk?
During this weekend's Liver Meeting 2023, Surfing the MASH Tsunami has interviewed some of our guest opinion leaders on what they found most exciting about the program. Today, Roger Green speaks with British hepatologist and entrepreneur Dr. Tim Jobson of Predictive Health Intelligence about presentations he is giving in Boston and other topics at the meeting he found valuable.
Hi, this is Roger Green, host of the podcast, now officially known as Surfing the MASH Tsunami. Our coverage of the Liver Meeting 2023 starts with individual interviews with some of our friends who participated in the event. Over the weekend, we will release our first group wrap-up with another release planned for early next week. Our second interview is with our good friend, Dr. Tim Jobson of Predictive Health Intelligence, Somerset, UK. Tim and I discussed the posters he's sharing at TLM, plus some other issues on improving identification and treatment of underserved patient populations. Tim has a unique and uniquely practical point of view on all this. I'm sure you'll enjoy it. And this afternoon, we're here with Tim Jobson from Predictive Health Intelligence. You may recall Tim having been on podcast earlier this year talking about some of the work that Predictive Health does. And it's your first time ever at AASLD?
No, I'm here last year in Washington, D.C.
You were in Washington. You know what? Yeah, I remember you in Washington, D.C. because I couldn't find my way to your party. I was frantically emailing James, I want to say 11 times in the span of 2.5 hours, and it didn't work. So now I remember you. I remember you were there, and B, I remember why I might not remember that you were there.
Yeah.
So how are you finding this year as compared to last year in terms of the general level of knowledge, interest in NASH? And we'll get to your specific zone in just a minute. But
yeah, so it's huge. It's pretty big last year, NASH in general, but it is a huge part of this conference. A lot of interest, I think, coming in the terms of early identification as well, and also using data for treatments. Then you go to look at the trials that are coming through. There's a huge number of assets now coming through for treatment. That's one thing I've taken away. The landscape for treatment is going to change dramatically over the next 2 to 3 years.
Everybody knows, not everybody, but everybody who knows the date March 14th, which is the date by which resmetirom has to be reviewed by the FDA. What do you see over the next 2 to 3 years? What other things, from what you hear in this meeting, do you see coming in that time window for treatment modalities?
Treatments like the GLP agonist, that is going to be making an impact. So I think that's working very early in the pathway towards developing metabolic syndrome. Those are clearly going to have an impact, I think. And the interesting thing about those drugs is they improve liver health, they improve your metabolic health, but they also, obviously, they're diabetes treatments originally, but also now cardiovascular. Good evidence coming out that they help. So I think it's going to be a significant change going forward.
I
because these are all one disease. Yeah. It's all one disease, it's all one syndrome.
Well, but yes and no, right? I mean, if only 20%, maybe or 22% of people with MASLD proceed to MASH, then there must be something going on within the data that will predict whether a patient with MASLD will progress or not. Now I think we're getting closer to where you live, but I don't know if you're presenting a paper on that or exactly what at the meeting, but do us a favor, talk about what you've been presenting, and then I want to come back to this question of the transition from MASLD to MASH and how can you help identify it?
So we've had 2 abstracts here, 2 posters. This time we're focusing on using our case-finding approach in areas of deprivation.
Yeah.
So because we can target subgroups of the population, we have postcode and deprivation data. We've shown a number of things. We've shown that blood-borne viruses, it's not in the MASH rate, but it's really important that there's more patients missing from care, and we can find them. So we can go and find people.
And is that an abstract at this meeting?
Yes.
Okay. Yeah. And what interest has there been in that abstract from people here, and why?
Some really strong interest, actually, from people back home.
Okay.
Particularly, the big metropolis. So we've got data in a fairly rural setting, not much immigrant population. If you take this information to London or to any other big city, this becomes a real game changer because you can actually find the areas you need to target to find patients with known hepatitis B, in a sense, because because they have the blood tests, but they're not in care, and find them and bring them into care. And that's going to be hugely important. We're going to get, hepatitis B under control or even eventually eliminated. The other bit of data that we've presented is about people in deprived areas having broadly similar rates of liver disease to the rest of the population, but more advanced disease. So we don't know why, because we know they're having lots of blood tests, we can see them, but we know for some reason they're progressing more rapidly. So there could be other influences on that, for example, lifestyle influences, diet, and so on.
Is there high concomitance with diabetes in that population?
We haven't done that work specifically, but I think so. Yeah.
Our last interview in this series, most recent interview in the series today was Zubair Younasi, who was talking about a lot of his epidemiology work, and a lot of the conversation was about the concomitance of disease, the estimates that the concomitance is increasing, and the importance of that, well, for a variety of reasons, but one notable one being that patients with diabetes progress through F3 a heck of a lot faster. Yeah. So if you think about the economics of the disease, quality of life becomes affected as soon as fatigue sets in, and that's frequently a lot earlier, even if people don't know what this fatigue is compared to depression. But the economics change dramatically when you get to your first decompensating event. Do you have work on that?
We don't have work on that. I mean, using our tool, we can find patients with that very easily. So as well as primary liver tests, we have everything else you look at in the clinic. So we would be able to risk stratify by diabetes markers, by HbA1c. We can also look at lipid profile as well. So all of those things allow us to then focus on a particular subset of disease.
Okay.
That's a work in progress at the moment, but it's certainly something we can deliver.
Well, can you talk a little bit about the work in progress? Is there a work in progress you can talk about?
Yeah, there's lots. Yeah. So where there are a number of diseases where looking at past blood tests, you can make a diagnosis really rapidly. So that's kind of the easy bit. That's the low-hanging fruit. Going on from there, we think the power of this is in sort of population level risk stratification. So huge numbers of people have had blood tests. Nobody's taken a look at that and said, what's the pattern? Are these people at risk? How do we combine that with other modalities to get a genuine way of risk stratifying at a population level? So we're funded by Innovate UK to do another study over the next couple of years, looking at a combination of biomarkers within the platform, and then in addition, transient elastography and CAP scores and genomics panel. So clearly some of the driver towards more advanced disease will be encoded in your genes. It won't all just be lifestyle and phenotype, but your genotype is really critical to this. So the question our research is going to hopefully help to answer is, can we identify at an early enough stage on the basis of pre-existing blood tests, what your liver imaging is like, fat storage and stiffness, and the high-risk genes that are going to predict progression? And then we can target
besides PNPLA3, what else do you look at in that kind of a setting?
So we haven't finalized that panel yet. Okay. So we're just literally starting up, and we're debating what's going into that panel at the moment. So
that's exciting. It's exciting.
But overall, we're talking about a 5-fold odds ratio. If you get the polygenic risk scores right, that's sort of the level that's being published in the data.
So what will the 5-fold increase mean in terms of the results of the project for the people who are sponsoring it?
I think what it's going to mean is that we will see people who have those genetic markers along with the pre-existing blood tests and so on have advanced disease later in life. Yeah. So in the 50s and beyond. But what we want to do is say, okay, can we find those people in the 30-year-olds? Because in order to change the outcome, we need to target these people much earlier before they've got advanced disease. Right. So these are the group which map to the older group with advanced disease. These are the high-risk ones. We can identify them, and then we can target resources at them.
And you can do that using, for the most part, things that are readily available, right? I mean, you're not going to have liver scans if you don't have liver scans, and you're not going to have the genetic tests, but everything else.
But everything else we have,
right?
Yeah. And so we can look at existing blood tests, and we can pull out people who then think, right, we need a genetic panel on this subgroup, and then further refine that into people who need intervention.
Yeah, that's really important, because I don't think we're going to be able to afford to do, even in the States where we waste money on healthcare like water, I don't think we're going to be able to afford to do genetic panels on everybody with, say, an intermediate FIB4 score, which one paper yesterday actually suggested.
And even the availability of transient elastography is not universally available. We're not in a position at the moment to go and scan the whole population.
Although NHS is working on it, right? I mean, as compared to the US, where no one's working on it.
But it's still opportunistic. And what we're trying to bring is is systematic approach to this, make it much more focused and something that can be rolled out at population level, rather than being sporadic, one group, then another group, then another one, and so on.
Got it. So if I can only scan 40% of the population in a given year, only is or a pipe dream goal. So let's change it. But if I can only scan 20% of the population in a given year, I'd like to make sure that those people have a far higher propensity to disease than the 80% I'm not scanning.
Absolutely right.
No reason to waste a scan.
And we're starting at maybe even 7%. We think you can make a massive impact just by scanning the high risk 7%.
Oh, 7%, I'm sure you can. Yeah, that makes great sense.
So how do we funnel down to that group? And then that actually makes it economically viable as well. It makes it something that the health system can actually afford to do. So obviously you've got to scale up the resources, but you can make this something that's cost effective.
When you talk to payers in this meeting, do they feel they've got the data necessary to be able to execute a system like that?
So the data in the US is more challenging because it's more fragmented. And obviously in the UK, we're off to a good start because we have a unique identifier across the NHS.
Yes.
So those are the things you need. The counter argument to that is make the data import you need, make the data set you need really simple, which is what we do.
Right.
And make the data processing required in the initial processing really simple again. Just serve up the raw data and then let the platform take care of all the clever stuff. It can be done.
So it becomes kind of a cheap, quick screen kind of? Is that what you're talking about? Relatively. Relatively. Once you've got the data in, but you've also got flexibility. Yeah.
So you can change what you're looking for and you can develop your model further. You're not fixed on doing a particular set of processing. Once the data's in the platform, you can analyze it.
And I'm sure that's a really compelling proposition in the UK because I know how the UK thinks about this stuff. You're finding people who are really interested here as well?
Yeah.
That's a step forward.
Finding people globally who are interested.
That's a step forward.
So people are really interested in, a large footprint in the US. We're getting to the stage of how would we actually do this in practice? Who are the stakeholders? Who do we need to engage? Not just payers, it's clinicians as well.
Sure.
They've got a real stake in getting this right. And the clinicians, once they see what we're doing, pretty much get it straight away. Yeah, this is going to help us do what we need to do for our population.
Just one more very American question. Is there a return to the clinician in the U.S. to be part of the system? Or is there a return to the system and the clinician does it because it's good medicine and saves some time?
Yes, it's a bit of both.
Tim, that all sounds fantastic. Very, very exciting stuff. What else have you picked up at this meeting that isn't about what you do exactly or directly?
I think one of the areas of interest in rare diseases. So we've got the huge MASH problem. Mm-hmm. There's a lot of interest though in rare diseases. Alpha-1 antitrypsin in particular, it's generated a lot of interest. There's still an awful lot of interest in PPC and a lot of pharma interest, but a lot of research and basic science as well. So I think it's a great spectrum to see. You've got the hugely common diseases, you've got the rare as well. Mm-hmm. So that's certainly something I've taken away. I think the other thing that's coming, which partly relates to us, is where does AI fit into all this and the disparate views? AI looks great on the surface. It looks very powerful. And then people realize it's actually quite tricky to handle. And what is it actually going to give us back?
Well, AI for what, right? I mean, so here's the question behind my question. I hear what you're saying. I think that we're seeing remarkably powerful pictures of liver zones created in AI right now through companies. Well, look at name companies. One of them sponsored them. And in that context, AI would not be used for the typical patient, but is really helpful for drug developers, right? If I can figure out the zone in the liver in which I'm having impact, then when I want to do combination therapy, I know what I have to do that I'm not doing, which don't be redundant, right? I'm having a hard time personally getting a vision how AI, sort of that level of AI, gets used in treating patients. So what are you hearing that is sexy but you think won't work out, or are we in a different zone?
Yeah, so I mean, there was stuff around listing people for transplantation. Yeah, so can the system help us predict who's going to do well with transplantation, for example? Can we use AI to integrate all the data much more easily? And the simple answer is yes, but, and the big but is around all the biases that we have in our data are migrated into the AI through its learning sets. And that's a huge problem. So the AI is learning on what humans have done, but we've got all our biases as well. So it's not a magic bullet. It's not going to solve those types of problems.
No, you need to go all the way out to neural nets and collect every piece of consumer consumer data you ever had on anybody and find out that the ones who drink Pepsi have a bigger problem than the ones who drink Coke. But we're not going to do that. Or vice versa. Sorry, I don't mean to offend any cola companies. But yeah.
But even that sort of work, there's still all the bias comes into that, because it can only, the data it can see is only the data that's there. And so the biases that drive the quantity of data that, say, on the internet, whatever your learning set is, will be then hardwired into the neural network or whatever the system is.
Yeah, I get it. Well, so then the question becomes, is that better than nothing, or better than what we have now? And I think the answer is, how could you know, right?
It's going to happen, isn't it? So where were we with using the World Wide Web for liver disease and gastroenterology 25 years ago? I actually did a talk on it back then, 25 years ago, on the World Wide Web and how it's going to change us. And we look back and see how massively our lives are very different from that. So these technologies...
You mean we were a little idealistic?
I think we understood at the time some of the benefits, but we also said we were going to solve a lot of problems that we probably haven't solved along the way.
That's a longer way of saying yes. Huh?
It's a longer way of saying yes, except that there are things that we do now that make our ability to do research and analyze data and understand the literature and all those things so much better than they were. So that's a real enabler.
Oh, there have been real benefits,
There's been some massive benefits. The point is, whatever you said at that time, whether it was good or bad, it's going to come. These technologies are going to come. They're going to change the way we work and the way we do our business. So I think it's coming. It's important that we all get a grip on it, understand it as best as we can, and use it in the best way we can.
That's really intriguing, because what you're suggesting, going back to your previous comment, one of your previous comments, is that at that point the biases get hardwired. For those who aren't watching, which nobody is, Tim just nodded yes fairly enthusiastically.
Yeah, it's absolutely true. But that's probably been the history of lots of these developments, is past mistakes kind of get hardwired in.
Well, the history of markets in general is the best technology that is good enough and has excellent distribution wins, which means, in fact, that it isn't the best technology that wins. So you're automatically getting biases by using second best or third best technology, well distributed. But I guess the really interesting question is, over time, do successive generations of technology that can absorb more data from more sources minimize error by absorbing data from outside the original loop, or is it impossible to get outside the original loop, in which case all they'll do is really hardwire, triple hardwire, and hold error?
And the most important thing is that we all engage with this technology as it comes and understand it as best we can and understand its limitations. I think there's been a drive around AI saying this is a solution to a whole load of tricky problems, and it is, but it comes with caveats, doesn't it?
Yeah. What else have you seen in this meeting you find of interest?
I think changing landscape around bloodborne viruses, the Hep B story and the Hep C story. I think we are further away from our goals than everyone would like to be at this stage. I think that's certainly true.
Do we know that, or is that your assessment that people haven't caught on to yet?
I think it's a bit of both.
Okay.
I think there's some ambitious targets around elimination, and I think people are realizing they're not going to be met, and that it's slightly more tricky to find all the hidden cases and get the care to those people. And there's a whole lot of other influences around economic and socio-economic influences that mean it's actually going to be harder than we think. So there's a lot more work to be done, finding people, treating people. We've got the treatments. We now need to get them connected to the right people.
So, silly question. What proportion of the right people could we identify today if we had the best technology to apply to it? Which I guess is a long way of saying how many of those people don't have data we don't have the data we need to find out who they are.
Globally, it's huge. So because particularly something like hepatitis B and its distribution globally means that the data simply isn't there at the moment. My experience in the UK is that even though and this is data we published, even though we do the right testing, we identify a lot of people, we still don't have them in care. So we only have 2/3 of the people, or half to 2/3 of the people actually in care who should be. There's a big gap, even on people we know about. So we can start making progress very simply by just eating into that group.
So there are three groups of people. People in treatment, people we can identify where we have the data to know that they should be in treatment, but they're not. And people who should be in treatment that we don't even know who they are because we don't have enough data to prove it yet. The first of those two latter groups should be easier to get after than the second one.
And we can do that now. We are doing that now, but that needs to be done at scale. There needs to be searching the whole population and finding those people, not just a fraction of, a portion of.
Does it need to be the whole population, or is it simply efficient for the whole population? You have my question, right? If you take a geographic slice of 8% of the U.S., it basically feels like the whole U.S. I'm not even sure that slice exists, but let's hypothesize that it did. Would you be less efficient in that 8% than you would be in the whole population? As compared to, I get one town of 12,000 people, another town 15 miles over, the town's going to be completely different. I need two algorithms. If you're just cutting swaths of population.
So you can be just as efficient, in a small as a big population. But you're only solving that proportion of the problem. So yes, get self-sufficiency in a segment of the population, but in order to achieve the goals of elimination, for example, the gain is much less because
because in fact what doesn't get done outside will seep back inside.
Exactly.
But it also says it's consistent. Part of my question was about the efficiency of piloting. What I think I just heard you say is piloting can be quite efficient because scale is about success of the outcome, not success of the identification.
And this is becoming easier because we can now manage large data sets much more easily than we could even 5 years ago, and certainly 10 years ago. So whilst, pilot on a segment of the population, scaling that is so much easier because data storage, data acquisition, that's going to be, that's easier. We've got the tools to do that now. Mm-hmm. So where that might have been a real inhibitor 10 years ago, it isn't now.
Yeah.
And we can do these things at scale.
Excellent.
And that's how you make the impact.
So this has been a fantastic discussion. Thank you for your patience with having to stop. Ideally, you won't hear this, listener, or hear it much, but we were given a space that we were told was pristine and quiet, and it is, except for the carts that keep rolling by, moving food and beverage from one place to another. So we've stopped and started in the middle of sentences. We're depending upon the high-quality work of our engineer magic, Mike Wilson, to get a lot of that sound out of the background, even though we're all on the same track. So it'll be a challenge for him. And so, Tim, congratulations. It sounds like you're making tremendous progress since we saw you several months ago. And I'm looking forward to catching up and interviewing again, maybe easel, maybe earlier.
Thank you.
Okay.
Thank you.
Okay. Bye-bye now.
Bye.
We will not have a business section for these individual interviews. I'll be back probably tomorrow with the next of our Liver Meeting 2023 follow-ups. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.